Good morning, everyone. Thank you for attending our Grand Rounds lecture. My name is Harika. I'm one of the first-year cardiology fellows here, and I am pleased to introduce our speaker, Dr. Nicholas Johnson, who is the Director for the Center of Inherited Myology Research, Professor and Vice Chair of Research in Neurology at VCU. He completed his neurology residency and combined fellowship in neuromuscular medicine and experimental therapeutics at the University of Rochester, and he leads the GRASP GMD Consortium and co-leads the Myotonic Dystrophy Clinical Research Network, which focus on developing clinical and biomarkers in limb-girdle muscular dystrophies and myotonic muscular dystrophies internationally. We are grateful for Dr. Johnson's experience on this topic, and we look forward to hearing from him. At the end of the lecture, we'll have time for questions. You can submit the questions via the chat function or raise your hand via Zoom. And we're pleased to offer both CME and MOC credit for our grand rounds. To claim the credit, you could text the code shown at the beginning of this presentation and also at the end. And I'll now turn it over to Dr. Johnson.
Thanks for the kind introduction, and good morning, everybody. Thanks for having me to your grand rounds. So I'm just going to kind of take you on a tour through myotonic dystrophy today. Some of the work that we're doing and stuff that is, I think, relevant, particularly for the cardiac care of these patients. So these are my disclosures. So just as a reminder, myotonic dystrophy type 1 is an autosomal dominant condition. The core features, the classic triad, is that, there's distal muscle weakness and wasting, there's early onset cataracts, and then there's myotonia. If you haven't seen myotonia before, what we're talking about
and open
is really the inability to relax muscles. So you can see this person is actually trying to open her hand as quickly as possible and just cannot. And that's really, we'll talk about that specifically due to a chloride channel dysfunction, but it's in the name of the disease. It's part of the hallmark of the disease. But it's truly a multi-systemic condition. And affects, as best as I can tell, nearly every organ system in the body. So, respiratory failure is one of the most common causes of death. Cardiac arrhythmias is also, one of the top two most common causes of death. I'll go into a little bit more detail about that. These patients develop cataracts. They have severe gastrointestinal symptoms, so it almost looks like an irritable bowel symptom, with diarrhea and constipation alternating. They can have insulin resistance and thyroid dysfunction. The brain may be affected. They have problems with sleep regulation, daytime sleepiness and fatigue, and a range of kind of behavioral and cognitive changes, including dysexecutive function, autism, ADHD, et cetera. And actually, there's an increased risk of cancer across the board. So all in all, it really does affect every organ system in the body. So if you ask patients what's important to them, they often talk about difficulty with muscle weakness, fatigue, and daytime sleepiness there. You see is that kind of the top three issues, along with balance issues and myotonia. In an alternate study called PRISM-1, there are problems with fatigue, limitations with walking and mobility, and then inability to do activities and problems with hands and arms, and then daytime sleepiness. So these are kind of what patients care about. But, obviously we monitor all of the symptoms that we talked about there. So even though it can cause everything, it doesn't necessarily cause everything. So when I was at my last institution, we used the Utah Population Database, which is a population-based database that collects demographic and health information on every individual that lives in Utah. And so we identified individuals with, the ICD code for myotonic dystrophy, and then matched them, to a larger general population. So if you look at that comparison, you can see the relative risk of any cardiac conduction disorder is about 60 times the general population. And if you look at kind of the mean age at which that comorbidity was diagnosed, as it was put into the medical chart, it was about 40, but you can see that there's a pretty wide range from 18 to 48 in terms of in this population, when was it first put in that they coded for a cardiac conduction disorder. Other things you can see, obviously sleep apnea, as we talked about, quite high, both either central or obstructive. cataracts you can see. And then in this population, the risk of cancer was testicular and chronic lymphocytic leukemia. Other studies have looked at different kinds of cancer, and it tends to be reproductive tract. So ovarian, uterine, testicular, although GI and breast and CN and brain cancer have also been reported in different epidemiological studies. So we here in Virginia are part of the MD StarNet. So this is a muscular dystrophy surveillance program that's funded by the CDC. And cases are ascertained from a surveillance population in Virginia, excluding Northern Virginia, North Carolina, the Piedmont region, South Carolina, Western New York, Utah, and Iowa. And they basically what happens is that if you have been seen anywhere in Virginia, like I said, except for Northern Virginia, we've tried to track down your chart, and we pull about 10 years worth of clinical data and that as abstracted. And then from there, we can classify individuals as, they definitely have myotonic dystrophy, which means they have a genetic confirmation or a first-degree family member with a genetic confirmation and typical symptoms. They can have probable myotonic dystrophy, which is without the genetic confirmation, but very typical symptoms. And then they can have possible, which means, they were seen like in the ER and somebody said, well, they might have myotonic dystrophy. So of the 429 individuals with definite or probable, you can see here the summary of the results. So, out of the, pretty high probability of having an abnormal heart rhythm, which you can see there, and a very low probability of having a cardiomyopathy, particularly if you consider, the rate of cardiomyopathies in the general population. And so I think, one of the key take-home points here is that, the cardiac care of these individuals really should focus on the arrhythmias that develop as part of the condition and how to manage them. So, and then sometimes it's unclear, if they have type 1 or type 2 myotonic dystrophy, who's more likely to have a cardiac arrhythmia. And you can see, by comparison, much higher risk of having cardiac arrhythmia with myotonic dystrophy type 1 than in type 2, and about equal odds in terms of whether or not they're men or women. So if you look at the characteristics of these individuals associated with either an abnormal heart rhythm or a cardiomyopathy, like I said, much more at risk of having cardiomyopathy with myotonic dystrophy type 1. A little bit higher risk of having cardiomyopathy, interestingly, if you have a later onset of disease. I think maybe that's just because of the age of the patients. It's hard to know, try and track that down. And then, there was for those individuals with more severe myotonic dystrophy, as measured by their repeat length, which is one way of looking at it. So if you look at kind of these different repeat length bins versus the DM2 as a control, there wasn't really an association. So again, if somebody comes into your office and they have myotonic dystrophy type 1, they are at risk of having an abnormal cardiac arrhythmia, and you really need to monitor that closely. So what causes the disease? So myotonic dystrophy is caused by CTG repeat expansion at the 3' untranslated region of the DMPK gene. And what that does is it creates a toxic RNA that sequesters RNA splicing proteins. So normally, what happens in myotonic dystrophy is you have this large repeat, it forms toxic RNA, and it sequesters these muscle-blind proteins. And you can see that in this graph here. If you look at cells with myotonic dystrophy, you can see these little foci in panel F, which is the muscle-blind proteins, and those co-locate with these toxic RNA repeats. And that's really the underlying cause of the disease. So what's the result of that? Well, muscleblind is an RNA splicing protein. So its job is to appropriately either include or exclude exons. So you can see that with the myotonic dystrophy, because it's sequestered, the normal inclusion product is not made. Instead, you make the exon exclusion product, and that is typically not functional. And that's really seen throughout the entire body. But some examples of that, like I said, the chloride channel is not spliced appropriately, and that's what causes the myotonia. The insulin receptor is not spliced appropriately. That's what causes the insulin resistance. And then for the cardiac conduction deficits, we think SCN5A, for example, is not spliced appropriately, and that's what causes the arrhythmias. So there currently are no therapeutic options approved for affected patients. But management, we'll talk about management in a second. So it is a very common rare disease. I think we think that myotonic dystrophy is typically underdiagnosed. So we took 50,000 consecutive newborn blood spots and just said how many of them were born with a repeat consistent with myotonic dystrophy. And we used a triplet prime PCR to screen and then did a confirmation. And here you can see the classification here where there were 143 positive samples, which leads to a prevalence of about 1 in 2,100, which is much higher than what people think was true in the past. And then we didn't talk about this, but there's this pre-mutation, which we think is at risk of expansion in subsequent generations, and you could see that's quite high. So really, it's a pretty common, like I said, pretty common rare disease. We looked; they were not related to each other in that birth cohort. And then if you ask, where are they from or where their family's from, typically these individuals were European, admixed Americans, Asian, and then consistent with other studies, it is myotonic dystrophy is not seen a lot in Africa, so it's lower in that population. So that high prevalence highlights the difficulties in the diagnostic odyssey. On average, patients wait about 7 years for diagnosis. Patients without family history are at highest risk, and it's commonly diagnosed in families with congenital form. I think pertinent to this audience, one of the challenges is that with all those different symptoms, these patients might come into the healthcare system really any place. They might see a cardiologist first. They might see a neurologist first. They might see an ophthalmologist first. And so it's important to kind of keep this in mind when you see people with those cardiac arrhythmias. So what are the cardiac care recommendations in myotonic dystrophy type 1? This is published on the myotonic dystrophy website. So they recommend a baseline ECG annually to consider cardiac imaging at baseline and then to monitor if it's abnormal. EP testing with a serious conduction block, and then the use of anti-myotonia medications like myxillatine with caution, especially with an abnormal ECG. So one of the things that often happens is that you can treat that the myotonia with any sodium channel blocker, like basically, old antiarrhythmic medicines. And so people commonly use myxillatine to treat that for symptomatic benefit. There's always a concern about whether or not it's going to produce or cause more arrhythmias. And so you might get that question from clinicians. There was a phase 3 clinical trial looking at myxillatine, and they did Holter monitors, and they didn't see a significant difference in the arrhythmias between the placebo and the treatment group, for what it's worth. And then obviously a pacemaker or ICD may be considered with those abnormal ECGs. Outside of the cardiac care, the current treatment is focused on the symptomatic care of daytime sleepiness and myotonia. The care should be performed in a multidisciplinary environment, and the mean age of death is 55, typically from cardiac or pulmonary causes. So we've done a lot of work to try to prepare for clinical trials and to improve our understanding of this disorder. So the Myotonic Dystrophy Clinical Research Network was originally formed in 2013 to develop clinical outcomes for myotonic dystrophy. And the rationale was to understand which outcomes were sensitive to change, to prepare sites for therapeutic trials, and to prepare patients for clinical trials. And so these are the myotonic dystrophy clinical research sites. So you can see the coordinating center here is at VCU, but really sites across the United States, Europe, New Zealand, and Japan. And our current study that we're doing, one of the current studies that we're doing right now is the NDM1 study, which is to characterize the severity and the progression in a large cohort, over 700 individuals with myotonic dystrophy type 1, and to complete the development of a biomarker. And this is exactly what we're doing. So it's enrolling 700 patients. We are now about 470 patients enrolled in the study. It's across those different centers. It's funded by the FDA, the foundation, and then a variety of industry partners, which you can see at the bottom there. It's a pretty simple study with, potentially muscle biopsies at baseline, 3 months and 2 years in a very small cohort, and then study visits at baseline 1 and 2 years. I will tell you at those study visits, we do collect a standard ECG that's uploaded into the database that I don't think anybody's looking at. So, I mean, we're looking at for safety, but not for changes. So, what have we learned, or how do we think about outcome measures in this condition? Well, one way of thinking about it is that it's a slowly progressive condition. So this is a vector plot showing about 100 individuals with myotonic dystrophy plotted at baseline and 12 months. And you can see between these two different cohorts that the overall percent change is about 5 to 6%. So it's really quite slow in that 12 months, but that hidden within that modest change, you can see that individuals over 5 seconds do seem to have a little bit, there's individuals who have changes over 5 seconds that look like they're a little bit faster progressing. And that's really the current study is designed to buttress those findings and to expand that cohort to make it statistically significant. Another way of looking at it is looking at the forced vital capacity. So if you look at the percent predicted forced vital capacity supine, you can see again that the change is about 5%, and that it's consistent across studies. But similarly, for those individuals whose percent predicted drops below 80%, you can see there's a group or cohort in there where the change is more rapid than what you might expect otherwise. And then thinking about the myotonia specifically, this is a difficult outcome measure. I spend a lot of my time thinking about it because it's if you look at the hand impairments on the bottom, you can see actually that it's a difficult concept because you have myotonia that develops, and then as the weakness develops, the myotonia actually improves because it's less hypoexcitable. But in general, people don't really separate out their myotonia, their weakness. They just talk about the fact that their hands are getting worse and they're harder to use. But as an outcome measure, our job is to try and parse out the difference between these two pieces. So that's been difficult, but it's actually quite important because you can see that if you use an antisense oligonucleotide to knock down the DMPK transcript, that the myotonia score drops quite quickly in the mouse model. And actually, if you do this in human studies, it's the same. In humans that have been treated in our clinical trials here and other sites, the myotonia is by far and away the first symptom you see improve. Okay, so the foundation for the study, you can see again, it's a slowly progressive condition. It is progression about 5 to 6% per year on a number of different outcome measures, and you can measure those outcome measures reliably. Switching to biomarkers, so RNA splicing, is the result of what happens in myotonic dystrophy type 1, and you can see that if you look at an individual splicing event like class 1 here, for example, there's an actual dose response with the amount of the muscleblind that's sequestered. So, but it's a little bit parabolic. So if if you can think about it, if you're severely affected over here, that there's not going to be much change in the splicing. If you're not severely affected over here, that there's can be quite a bit of change, or again, not a lot of change. But if you're in this kind of middle range or moderate severity, you can see a lot of shifts quickly. And each one of these RNA splicing events has their own dose response curve related to the amount of the muscleblind that's sequestered by the repeat. And so it's a little bit tricky. If you think about it, how many events should you use to be able to predict what the actual MBNL concentration is? And it's just showing you some different examples of the predictive power of a number of different how many events you would include and what your predictive power would be. So it turns out for us, we used 22. And that was based largely on work that was done by collaborators at Rochester. And here you can see this is looking at several different RNA splicing events. This is looking at the ankle dorsiflexion strength here. And you can see that as, for some events like BIN1 or NFIX, you can see that there is some shift or changes as the muscle weakness develops and people, have a wider range or you can see that the splicing biomarker shift with the weakness. Other events like insulin receptor or Titin, for example, are not very good biomarkers because they don't really shift very, very much. They're quite sensitive to that loss of the MBNL because they change almost immediately. So what we've done is to take muscle biopsies of the tibialis anterior. We used, like I said, 22 different events that demonstrate large effect and correlate with TA muscle weakness. And you can see here, look at the composite splicing index and ankle dorsiflexion strength as a percent predictive normal. There's a very strong correlation there. And then similarly, even if you're not biopsying the hand strength, there's actually a good correlation between hand strength and that splicing biomarker. What's interesting to us and was maybe a little bit unexpected is that it's actually predictive of future function. So if you look at the correlation here between the baseline strength and the 3-month strength predicted, there's a if you're using the splicing biomarker, it's a very strong correlation and association, and it's not as significant if you look at it compared to the baseline and look at an individual time point to an individual strength measure. So what is the therapeutic landscape in adults with myotonic dystrophy? Most people think that a conjugated ASO or siRNA knockdown or steric blocking of the DMPK transcript is possible. There's actually 3 companies right now with phase 1/2 studies ongoing that all of them are the ones that have reported out appear to have good results. There are 2 more planned in 2024. And then for 2 of those companies, Avidity, like I said, they demonstrated functional improvements in as short as 6 months in the data that they've released so far. So actually, I'm pretty excited. There's a lot of opportunities that are coming down the road for these patients in the very near term. So I'm going to switch gears and talk about children with myotonic dystrophy. The CT2 repeat expansion can occur between generations. So if it does, at birth, individuals may have congenital myotonic dystrophy. And if they have onset between ages 1 and 10, they have childhood myotonic dystrophy. So this is a family that I saw. So this is the grandfather who was completely unaffected. The red arrow here is actually the proband. So this child was born with congenital myotonic dystrophy and diagnosed in the NICU. And then he had an older sister who had learning difficulties and was diagnosed with childhood onset myotonic dystrophy, and had a cousin that was also subsequently diagnosed with learning difficulties. And you can see the 2 the mothers here who really had almost no symptoms at all. They had a little bit of insertional myotonia, but I think oftentimes this is how families come to light with this condition, is that there's a child that's born that's severely affected. So congenital onset myotonic dystrophy, facial weakness, intellectual impairment, autism spectrum disorder, ADHD, and then importantly, the weakness and myotonia develop later. This is a survey we did asking parents to rate the impact of various symptoms by the age of their child at the time of the survey. And you're not supposed to look at all of those, but you can actually see there's this kind of interesting triphasic pattern. So in the infant period, they have respiratory failure, feeding difficulties, clubfoot, and hypotonia. Those symptoms almost universally improved. The left in childhood, with this kind of quiescent period really marked by the intellectual impairments and GI issues. And then in adolescent, they developed the more typical adult features of the disease, so myotonia, fatigue, and distal weakness. And you can imagine with that triphasic pattern of progression, that both makes trying to understand how the disease progresses, but also how to design clinical trials really challenging. And so we have been a series of natural history studies where we followed about 100 kids with congenital myotonic dystrophy for the last 10 years. And I'm going to show you some of the data from that. So in general, this is how we define them. So they have to have congenital onset myotonic dystrophy and a repeat length greater than 200. And in this initial cohort, for the kids that were followed, you can see by and large, they had a very large CTG repeats. They're about equal, male and female. They did have respiratory support during the study. And then interestingly enough, about 8 of them had some sort of ECG abnormality. And actually, 2 of them ended up requiring pacemakers about the age of 10. So I think one of the earlier studies in myotonic dystrophy had suggested that individuals don't develop cardiac arrhythmias until later on in life. And that appears to not be true. That can really occur at any age. These are some progression plots looking at these kids. And so you can see, looking at their grip or pin strength, that they are quite severely affected. And frankly, they don't change that much on this outcome measure over time. On the right, you can see that there is a graph of the grip strength, and it's plotted against these dots. And those dots are normal pediatric controls taken from the 1,000 Norms project. And so you can see, they don't change a lot, but really one of the things that you can see, particularly in that childhood period, is that they start to separate out from the normal motor development. Although there's a few kids here later on that do seem like they are still gaining abilities. This is another way of looking at it. So this is looking at the 6-minute walk, 12-month progression. Again, you can see notably that these kids do gain strength and endurance over, before the age of 10. But again, after that age of 10, you can see that they really plateau out and begin to separate from those healthy controls. Looking at cognition, the mean IQ in these children is about 65, which is quite low. And there's a variety of other intellectual problems, either measured through their adaptive function on the Vineland or the executive function on the brief. And then looking at their a measure of autism, which is the ASAQ, you can see that there's the cutoff for the score is about 12. So they do meet the criteria for autism as well. So overall, you can see if you break the cohort out, that these 2 columns are the ones to pay attention to. If you look at the percent change in kids that are less than 10 years of age versus those that are more than 10 years of age, particularly on the 6-minute walk, you can actually see, they gain significant distance during that time. And then they seem to plateau for that about 5% change in those that are over 10 years of age. And then that's, others, it's much more stable between the 2 groups. And then drawing your attention to a measure of daytime sleepiness, you can see that decline really start to occur in those over 10 years of age, which is what we expect to see. That daytime sleepiness and fatigue is one of the first symptoms that develops from the adult features of the disease. So what's going on in these muscles? So we looked at RNA splicing and said, is this the same disease as adult myotonic dystrophy? And if not, why? And so we have muscle biopsies from 36 children with congenital myotonic dystrophy. You can see the age range here between really 2 weeks of age and 16 years of age. And then you can see compared to adult DM and then pediatric controls and adult controls. And one of the first things you notice if you look at these different cohorts is actually that the congenital myotonic dystrophy group is actually more heterogeneous than the adult group. So if you look at that chloride channel event, which is what causes the myotonia, you can see that the adults in our group were clustered up here as being quite abnormal. The kids were spread between normal and abnormal. Same thing here on a number of these different ones. So they're actually a little bit more heterogeneous than adults. But that they do share the same splicing event. So this is a heat map of the top 50 events, and you can see the adults in blue here mixed in with the children with congenital myotonic dystrophy. You have all your controls, and then there's this other group of congenital myotonic dystrophy patients that are sitting out here and looking quite normal and consistent with controls. So this is one of the take-home points. I showed you that triphasic pattern of progression that happens clinically. this is what their splicing happens in a cross-sectional way. So you can see if you look at a measure of RNA splicing with 1 being normal and 0 being abnormal, kids at birth really severely affected in terms of their underlying spliceopathy. But interestingly enough, in this cohort of childhood individuals, some of them have nearly normal splicing. And then in adolescence, you can actually see that they start to separate out. So some seem to maintain a fairly normal splicing score, and others seem to revert back to that more severe myotonic dystrophy pattern. There are 2 kids that had biopsies at several different time points. So this one here at 2 weeks and then at 8 years of age, and you can see that his splicing actually improved by about 50% on its own. And then this girl over here seemed to plateau. So this really is our challenge in terms of moving these new therapeutic trials into pediatric populations, is trying to identify those that have a splicing score that would be amenable to correction, which is quite challenging. We believe that in children with myotonic dystrophy, it's really a 2-part disease. So the DMPK expression is actually quite high in that earliest cohort compared to the other cohorts. And so really what we think is happening is that early on in life, the DMPK expression is overcompensating for their degree of CT2 repeat expansion. But then as the repeat expansion continues to somatically expand in adolescence, that really kind of takes over and takes, more consistent with the adult features. So really early on, it's related to the DMPK expression for reasons that we're not sure. That seems to silence developmentally, although we're working on it. And then in adolescence, it comes back. So can you find these individuals if you are with functional measures? Can you find those individuals suitable for clinical trials just by looking at different things? So this is work done by MD PhD students in our lab, and this is looking. You can see the different color codes here. This is looking again at that splicing score. For example, here, either in a mixed group with adults and kids, or in a group just with kids, which is what those shifts are. And you can actually see that, at least for like running speed on a 6-minute walk, or 10-meter walk run, you can see that it does have at least that consistent moderate correlation. It has a correlation with the ankle dorsiflexion strength. And then interestingly enough, the correlation is not very good, but it seems to improve actually on the 9-hole peg if you just include those kids. And so if you look at CDM only and you try to look at your predicted MBNO inferred by a percent change on walking speed or percent change on peg compared to the actual, there's actually a good correlation. So we think this is probably the future, our ability to try and select for those individuals with an appropriate degree of spliceopathy based on their walking speed or other functional measures in clinical trials. So treatment of CDM will require a different design. It's a more severe form of the disease. It has that triphasic pattern of progression, and there's significant CNS burden. But we're working very hard to try to tackle that here at VCU. So I'm running a little bit ahead, which is okay, I think. So myotonic dystrophy is a multisystemic disease. The preventable cardiac arrhythmias are the leading cause of mortality. The clinical features of CDM are distinct from myotonic dystrophy, but it's also a multisystemic condition. The symptoms in congenital myotonic dystrophy do generally improve in age, at least through childhood. The underlying pathogenesis of CDM is the same as DM1, but there are promising trials that are underway. And with that, to thank our faculty who worked on this, and all of our staff in the lab and the clinical team. This is our center here at our last patient day. We'll do another one of these patient days this coming April. And with that, I can take questions.
If anybody has any questions, feel free to put them in the chat. I'm happy to read them out loud. Dr. Johnson, I know you have a meeting at 8:30, so we can give it about a minute. And if there's no questions, then I'll pass it over to Shannon. All right. Thank you so much, Dr. Johnson.
So,
Great.
We appreciate you
Oh, yeah.
taking, yep,
Well said.
really appreciate you taking the time to talk to us.
Oh wait,
Happy.
Dr. Salim, were you going to ask something?
yes, I was sorry, I'm driving. I'm trying not to. But thank you, Nick. That was really a very, very nice overview. In the context of all the different forms of the disease that you mentioned and the intersection with the heart, I know there's a lot of work that's being done to look at the arrhythmias and some of the work that you had mentioned. Do you see any overlap with any kind of pro-fibrotic signaling that may be common between the two?
Yeah, I think we think that there probably is a development of some fibrosis, particularly in that conduction system. But people have not done, to my knowledge, really good cardiac MRI studies in these individuals. There is a new mouse model that seems to be pretty good at studying the cardiac signals, and in that mouse model, when they took those mice down, they saw fibrosis again in the conduction system there.
Okay, so mostly conduction system, not with
Yeah.
muscle wasting or any possibility. Okay, thank
No.
you.
There's no other questions. Thanks for having me.